sessions formally begin with this session. My name is Dr. Atif Majid. I am a consultant gastroenterologist, hepatologist at Dow University of Health Sciences, working there as an assistant professor. I am also a part-time consultant at the Hasan University Hospital, and I will be moderating this important session on surgery in a diseased liver. So the topic takes me back 6 years ago when I started off as a young attending, and we had a patient who had decompensated chronic liver disease and ascites, and along with that, that patient was admitted with a strangulated umbilical hernia. And unfortunately, it took us about 36 hours to convince the surgeons to actually operate on that patient for the hernia. And he was deemed high risk. There were a number of requirements that were being asked to go through. And then after 36 hours, finally, the surgeons actually opened him up and did the surgery. So I think the topic today and the speakers are brave people, the surgeons who actually operate on liver itself and in liver itself being diseased. So without further delay, I would like to introduce the chairs of the session, and I would like to request them to please come on stage. To start off with, we've got Dr. Amir Latif, and he's a transplant surgeon at Sheikh Zayed Hospital, a senior transplant surgeon with years of experience. A lot of introduction need to be added, but for the sake of time, I will not be able to go in details of the introduction of the chairs. Dr. Amir has been working in Sheikh Zayed for a long time now, and he's had a lot of his experience abroad as well. For our next chair, we've got Dr. Mohammed Saleh. Dr. Mohammed Saleh is a transplant hepatologist at Shah International. He's been my teacher as well when he was there at the Hasan University. He's a mentor to many. He's been an inspiration for many young gastroenterologists as well. And he's helped so many people along the way. He's worked in Shifa. He started off the transplant program as a team member in Qaid-e-Azam, and then he's now also working back at Shifa. And then thirdly, we've got our chair, Dr. Shahzad Riaz. Dr. Shahzad Riaz is also a transplant hepatologist at Shifa International, and he's also trained abroad, and he's got a long experience with him. So I welcome all the chairs to the session, and without further delay, I would like to move on to our speakers. Before the first speaker, we've got Dr. Najm Hasan Shah. Dr. Najm Hasan Shah is a very senior gastroenterologist. He's condemned me actually to give a long introduction of his, but I consider him to be a team maker, the one who broke the ice, the person who actually started off the liver transplant program in Pakistan. He was the one teamed up with Dr. Faisal Dar, started off at Shifa and then moved on to Qaid-e-Azam, and then he's moving in so many places. He's a well-renowned figure, and I would, without further delay, like to hand over the mic to Dr. Najm Hasan.
Thank you very much. The changing indication for liver transplantation is the topic for this morning. And I prepared my last slide last night at 2:30 a.m. Because when you meet people in the corridor and see who is coming, you want to make sure you don't make any mistakes, stupid mistakes in your slides. So I had to review several times. We all know that viral hepatitis C has been the most common indication for liver transplantation all over the world, in America, Europe, and Asia. And post-transplant survivals for patients with HCV were the lowest. And then initially in the interferon era, and then the protease inhibitor era, and then more potent DAS since 2014. This has changed, and this is because of the impact of these potent DAAs on all stages of the natural history of HCV. We know that SVR leads to complete recovery of liver injury in patients with chronic hepatitis C, and there are a great majority of the patients with compensated cirrhosis on the transplant waiting list in America and Europe has been shown to not progress to decompensated cirrhosis. And those who achieve SVR, there is even improvement in liver functions within months of people with less than 20 med sodium. And the post-transplant survival has almost equal, and I think even better, for the people with HCV as an indication for transplantation because of the potent DAs. And I think this has been reflected recently, this beautiful study from Journal of Hepatology, where they looked at the impact of DAs on the liver transplantation. And they looked at the major effects on the evolution of indication and results from the European Liver Transplant Registry by looking at the overall results and particularly patient with decompensated cirrhosis and HCC for the interferon era, the protease inhibitor eras, and the DAs eras. And I think the conclusion was that in Europe, the number of liver transplant due to HCV infection is rapidly declining for both HCV decompensated cirrhosis as well as HCV HCC. And post-liver transplant survival has dramatically improved over the last 3 years. We know that in Pakistan, DAs have been available initially as a patient access program in 2011 to 14, and then more imported brands became available. And then there was local availability of the local brands and free access to the antiviral therapies. And the aim of today's presentation is to see the impact of DAs on liver transplantation in Pakistan. And we will be looking at the pre-DAs and post-DAs period liver transplant data to analyze the impact of DAs, if there is any, on this activity. So the first one is liver transplant data for the pre-DAs period. I think I've been lucky. I was searching to see what will be the representative sample for this era. And I did a presentation way back in December 2015 to show the growth and progress of the only liver transplant program in Pakistan at Shah International Hospital. And we started the program in 2012, and by December 2015, we have done more than 250 transplants. And this presentation was in the PCSLD in December 2015. And you can see that this was a very good catchment from the national areas of Punjab, Sindh, KPK, and Balochistan as parity-wise with the population. And predominant catchment was from the Punjab with 56%, followed by Sindh 19.7%, and 11% from KPK and 7% from Balochistan. So it was a very representative data of the only liver transplant program, largest one at that time. The male sex was predominant in this group with almost 80% male population. The mean age was 43.99%. And out of 246, end-stage liver disease accounted for the most indications as a group. And within the group, it is very interesting to look at the etiology of the indications. With HCV, 79.91%, and hepatitis B, 9.28%. And the viral etiology actually accounting for more than 91% of the liver transplant in this cohort. 26.93% of these patients had HCC. And looking at the HCC etiology, HCV was the predominant etiology at 86.14%. So in summary, I think this pre-DAS period data shows a predominant male population with viral etiology with 26.93% HCC. And within the viral spectrum of decompensated cirrhosis, HCV as the leading etiology, while HCV again becoming the main etiological factor for HCC. And I think this serves as a good baseline to compare our results for the post-transplant DAS period from 2017 to 2022, assuming that there was more widespread access to the DAS by that time in Pakistan. There are two sources that can compare with a baseline. I moved to Quaid-e-Azam International Hospital in 2017, leaving Shifa. And soon Dr. Faisal Dar joined me. And then the 2017 to 2020 QIH data probably represents the largest liver transplant program activity in private sector for that era. And then both of us moved to PKLI in 2021 till 2022 with the same group. And I think if you look at the data of 226 transplants from QIH period, and I thought 274 when I was doing this analysis, and they've now reached to 300 at PKLI, would be a good representative data for the post-DAS period to see what are the trends. So first, the QIH. I think the catchment was again quite national, with Punjab, Sindh, KPK, and Balochistan represented as one would expect. So it's a good representation. Overall, mean age was 44.66, and male was 64.15% in this cohort. 69% of the patient had a viral etiology as a main indication. While within the decompensated cirrhosis, HCV stood out as the commonest indication at 70.06%. 26.10% had HCC in this cohort. And for the HCC etiology for this period, 72% had HCV as an etiology for HCC. But there was a growth in the non-viral HCC, 10%, which is significant. When you look at the PKLI data from 2021 to 2022, we had a mean age of 48.66, with predominant viral etiology again as an indication for liver transplant. And the viral spectrum for decompensated cirrhosis was 72.57% HCV. 25.10% of this cohort had HCC. And the etiology of HCC again, HCV was 67%. Now you compare this with the pre-transplant DAS data from 2012 to 2015, with the post-DAAs 2017 to 20 and then 22, and there are quite interesting trends in this data. The most important is that there was more access of the female population to liver transplantation from the initial baseline. And the viral etiology has shown significant reduction from 91.3% down to about 70%. Within the viral spectrum, there is again a trend and significant reduction in the HCV etiology for decompensated cirrhosis. But the HCC cohort sees a uniform quantum of like HCC. And the predominant etiology remains HCV, but if you look at the baseline data of 84.14%, there is a significant reduction in that HCV, HCC load as well. And the non-viral has significantly increased as an HCC etiology to about 10%. And also, the non-viral indications have grown substantially to up to 30%. So I think this data is very convincing that there is something that is impacting the indication for liver transplantation. However, this is only one group doing the test, but there is a phenomena happening in Sindh, in a jungle, where a man who was expelled in a way inverted commas from Shifa, and then he left us from Quaid-e-Azam because he didn't want to work with another transplant surgeon. And he has developed one of the largest liver transplant program in a jungle in Pakistan. And I thought it will be unfair to be presenting this data without looking into what they have done actually and what are the trends. So I called him, and he was very, very generous. He said, Dr. Najm, you have every access to all the data in Gumbart, whatever you want. And this is a sharp contrast to another transplant centers who were so shy and protective of their data. In this data, very important to see that the catchment was predominantly from Sindh, with 51% coming from the local catchment population, and 30.03% from Punjab, and then Balochistan stood out as 13%. So still it is a national catchment for that center. And they have done 656 transplants till date, from 2017 till date, which is a significant number. Their mean age, however, was 39.28 out of this 656 transplants. Male sex, again, predominant with 85.21%. And viral etiology is the main indication group for liver transplantation, 84.90%. But looking at the viral spectrum for decompensated cirrhosis, there is a sharp contrast in this group. The predominant etiology of the decompensated cirrhosis, 66% is hepatitis B or delta infection in this cohort, while only 34% are HCV. And we are talking about a post-DAA's era where this transplant center was set up and making progress. The HCC data is again very interesting because in this cohort, the 13.30% was only HCC. For the viral etiology, however, HCV is the predominant etiology for HCC with 57.47%. If you compare the Gumbart data with the other centered data, you also see a lot of interesting trends in this data. So if you compare now, Dr. Hamid, there's a lot younger population that is decompensating and presenting there with HCC and decompensated cirrhosis, 39.28%. And although the viral etiology is the predominant indication, there is a significant reduction compared to the baseline if we compare this with the Shah data from 2000 pre-DAS period. But look at this. The viral etiology for decompensated cirrhosis, only 28.6% for HCV. Is that because they have a more powerful DAS program within that region, and that's why we are seeing a reduction? Or is this just a regional variation of hepatitis B and C in that region? But when you look at the spectrum of hepatitis B, you see a significant load for hepatitis B as a predominant etiology in that region. So probably we cannot say that this is more effective DAAs, but there must be an impact of that as well. But their predominant etiology is actually hepatitis B in that region. The other thing is the HCC, very significantly lower compared to the other regional centers, national centers, 13.30%. So is this a reflection that actually, because their workload is less HCV, that the HCV is the predominant etiology for HCC compared to hepatitis B? I think this is how I read it, because they have more bulk of hepatitis B, we see less HCC. And I think that will be reflected in the HCV etiology, because if you were expecting a lot of HCC due to hepatitis B, we would have not expected HCV to be the main etiology for HCC in here. So that means that the HCV is the main risk for HCC. And that's why, because they have less HCV, their HCC load is less. I think that is how I read this data. Now, looking at the natural history of hepatitis C from acute exposure to decompensated cirrhosis and HCC, This is my favorite slide and personally made. We know that if 100 people get an acute infection, 4 will die of decompensation and cirrhosis over 30 years. Now, the time frame of 30 years is very important. And we know that people who have established cirrhosis, there will be a 6% annual progression to decompensation from these established compensated cirrhosis and 4% HCC annual rate. I just want to see the burden of disease in Pakistan. We, in 10 years ago, thought that there's a 5% HCV in the country. So you're talking about 11 million people. And out of that, 2 million have already progressed to stable cirrhosis by this, and 550 will have decompensation by now, within 10 years. If we say that the time period, and if we say the DAAs actually will make a difference, or would have made a difference, so if we would have offered and eliminated HCV, 11 million, how many would progress and add to the burden of cirrhosis? I don't know. Similarly, we don't have any data to say how many cirrhotics achieved SVR and whether we are able to reduce that burden. But certainly, the main question is whether we are going to see a further decline in HCV as we improve our DAAs programs, and what period of time will take for the HCV to be not the dominant indication for liver transplantation in Pakistan. I think the Gumber data is very interesting for me. And again, I want to highlight this hepatitis B. The main other question that came to my mind, that there was a significant hepatitis B in that cohort of 656 patients. And look, knowing the natural history of hepatitis B, why have we failed to see any impact of universal vaccination that has been available in Pakistan for the last 30 years? I would expected that all patients in Sindh would have received hepatitis B vaccination by now. But we still see a big burden of hepatitis B in that population. Now, coming to the non-viral etiology. In the SHIFA data, 48% had MASH, followed by Budd-Chiari syndrome, Wilson's disease, and autoimmune hepatitis. But in QIH, that parity remains, with 63% cryptogenic cirrhosis, NASH, and non-B, non-C, followed by the rest. And the non-viral spectrum with PKLI is no different, with 45% having NASH and non-B, non-C, and cryptogenic, followed by Budd-Chiari, biliary atresia, and PFIC. And the Gumber data has shown the similar trend for non-viral etiology of 43% NASH. Budd-Chiari syndrome was 21.64%. But if you plot the pre-DAAs and the post-DAAs non-viral etiology, you can clearly see that from the 8.7%, there is a significant increase in the non-viral etiology on the transplant list, up to 30%. And the spectrum of the non-viral etiology, the cryptogenic cirrhosis and Budd-Chiari syndrome tops the list. I tried to accumulate and analyze all centers' data for non-viral etiology to see a trend. And I can show you that 50% of the non-viral etiology comes as a NASH, cryptogenic cirrhosis, and non-B, non-C. But what about this? The rest 50% is actually pediatric transplants. And therefore, my interest, again, was to look at the pediatric data to say how we are doing there. And I called all centers to get the update on latest liver transplants in Pakistan. And this is, I think, till last month, the 2,820 transplants have been done as a living donor in Pakistan by 12 centers. 10 of that is still active. And I think this figure is now crossing 3,000 because Shifa has added more. I think they're crossing 1,200, and PKLI and other centers also have done more. While 153 transplants are only pediatric transplants, 2 are cadaveric only. So I looked at all centers' pediatric data to show that Budd-Chiari syndrome was the predominant etiology of 37% for the pediatric group, followed by PFIC, Wilson disease, and biliary atresia. Now that brings me to the last 2 slides to say the burden of end-stage liver disease due to non-viral etiology. We would expect a big burden in 220 million population for Pakistan. But we are seeing only about 153 transplants for that group. So in summary, I think there is an impact of DAs on liver transplantation. And this data shows a reduction in the liver transplantation for HCV decompensated cirrhosis and HCV-HCC, with a significant increase in non-viral indications in the pre and post DAs period. The HCC transplant load remains almost constant for pre and post DAs eras for all 3 centers. While the HCC is a major risk factor for HCC, while hepatitis B and Delta are comparatively low risk than HCV, while the HCV decompensated cirrhosis is far less in SIN compared to other regions. And for non-viral causes of chronic liver disease, the pediatric liver transplant workload is still very low across the country, and there is an urgent need to improve the prevention, diagnosis, management, and follow-up of patients with pediatric transplants. Thank you very much.
Dr. Najm, thank you very much. This is a period of evolution. Definitely this is something which is evolving, liver transplant indications with time. And we'll take the questions and comments in the end.